Good evening, everyone. I hope you are all well and ready to begin our special live event today. I am your host, Caroline, and I really hope you can hear me loud and clear. So please just let me know so I can make sure everything is okay. As you already probably can see, we have invited today Dr. Ahmet Ozyigit, a PhD and assistant professor at North Cyprus IVF. Hi, Dr. Ahmet.
Hello. Hi, Caroline.
Okay, I do see that everyone can hear me. That's very good. And of course, today Dr. Ahmed will present a topic on repeated miscarriages and their possible causes. And of course, let me just remind you a little bit on how everything works here. So we will start with the doctor's presentation that will take approximately 30 to 45 minutes. And then our questions and answers session will follow right after. So remember, you can type in all of your questions in the chat section. Now you can do it now or later on during the presentation or just simply after once we start a Q&A session, and all the questions will be answered by the doctor, of course, one by one. Please note this live event is being recorded and again will be available tomorrow on our site. So if you have experiencing any connection issues or needs you need to go somewhere, etc., do not worry, you will definitely have a chance to watch it again tomorrow. And I guess that would be it from my part, and I guess we can definitely start. Dr. Ahmed, are you ready to begin?
Yes, absolutely. Thank you very much, Caroline, for this
Perfect.
amazing introduction. And it's
Perfect.
always nice to be here with you.
Thank you. Go ahead.
And hopefully, as you said, I will be able to answer the questions. I'll do my best. I'll try my best.
Perfect. So here's the presentation and let's begin.
Thank you very much. Okay, so I would like to welcome everybody for tonight's webinar. We're going to be talking about something that's not very easy to talk about for people experiencing it, obviously, and especially if people have gone through it a number of times. It could be very traumatic. It would be very difficult to experience. So most people won't even talk about it. So hopefully, we'll try to address some of the issues behind repeated miscarriages, about recurrent pregnancy losses. I'm going to use the two terms interchangeably: pregnancy loss or miscarriage. And hopefully we'll be able to answer some questions and talk about the etiology, talk about the factors that cause miscarriages in general. Of course, I need to say that medicine is a very dynamic field. So we're discovering things every day, and it's all dynamic. It all changes. What we believe in one day may change the next day. So things are not very static. So we do discover things as we go along. And even though I'm going to go ahead and try to summarize, even though I'm going to try to cover a lot of aspects of recurrent miscarriages, keep in mind that this is not a comprehensive list. So there are other more rare, if you will, causes of recurrent miscarriage as well. And this presentation, this webinar, this talk should never replace a doctor's consultation. So having said that, hopefully I'll be able to clarify a lot of things. And if you have any questions, we do have a Q&A session in the end. And you're more than welcome to ask me any questions you like about this topic, of course. Okay, so let's get started. Before we get started, I would like to define what a miscarriage is, and then we can talk about what a repeated miscarriage or recurrent miscarriage is. First of all, a miscarriage or a pregnancy loss is the loss of a pregnancy before 20 weeks of gestation. So if it's after 20 weeks, then we call it a stillbirth. So it's no longer called a miscarriage. So a miscarriage would happen somewhere between, from the start of the pregnancy until 20 weeks of gestation. And broadly speaking, there are three different categories, three different types of pregnancy losses, of miscarriages. One of them is called complete miscarriage, and then we have incomplete miscarriages, and then we have missed abortions or missed miscarriages. Of course, and these terms sometimes are used interchangeably, missed abortion or missed miscarriage. So looking at complete miscarriages, these are the types of miscarriages that usually occur before 12 weeks of gestation. So when the pregnancy has not progressed, and the entire pregnancy tissue has already left the uterus. So there is bleeding, there are cramps, there is pain, and this pain obviously comes from the contraction pains because in this type of pregnancy, the cervix has opened and the entire conception products have left the uterus. So this is the type of miscarriage where it's still early during the pregnancy, and with the bleeding, the entire conception material has left the uterus. And then we have what we call an incomplete miscarriage. In this case, usually we're looking at a pregnancy that has developed a little further, so beyond 12 weeks of gestation. And even though in this case we still have vaginal bleeding, we still have the cramps because the cervix has opened and some of the tissue, some of the pregnancy tissue has left the uterus, but there are some tissues still remaining in the cervical canal. Therefore, the conception material, the conception products have not entirely left the body. There are certain parts of the fetus still left in the uterus or in the cervical canal. And the cervix is open. So in this type of miscarriage, even though the entire conception material hasn't left the cervical canal, usually what we do, or what your gynecologist would do, would be employ a wait and see strategy, because in most cases, within a few days or maybe a week or two, the entire conception material will actually leave the cervical canal on its own. But if the tissue doesn't pass on its own, there are alternatives that you can do. For example, taking certain medication like misoprostol, which will induce contractions so that the tissue can leave the body, or dilation and curettage, DNC, to remove the tissue remaining. And then we have missed abortions or missed miscarriages. These are the silent ones, and these are actually more common than most others. This is when you have no clue what's going on. You think your pregnancy is progressing, but you go into your 12-week scan or B scan at 20 weeks, and you discover that there's no more heartbeat or there's no more fetal movement. So this is the type of miscarriage that's a little bit sneakier than the others. And there's no bleeding, there are no contractions, there's no pain, no cramps, but the fetus is no longer progressing, the fetus is no longer active, but it's still in the uterus. So this is usually something that we see between up until 20 weeks again, but it's usually seen after the first scan. Okay, so the topic today, after giving you some basic definitions of what miscarriages are and what type of miscarriages we have, I want to talk to you about recurrent miscarriages or recurrent pregnancy losses, because this is our topic and this is what we're interested in today. And one of the things that I would like to emphasize is the precise definition of recurrent pregnancy losses or recurrent miscarriages. Because if you look at different sources, you're going to see that some of the sources define recurrent pregnancy losses as 2 consecutive pregnancy losses. And some of the sources will say 3 or more consecutive pregnancy losses. Even though 2 or 3 may not make too much of a difference, you may think, but in fact it does. And the sooner the better in terms of investigating into the possible causes, because traditionally in the past we used the definition of 3 or more consecutive pregnancy losses, and that often caused more pain than it's supposed to, because once you go through 2 consecutive miscarriages, the likelihood of having a third one is about 30%. And someone who experiences 3 consecutive miscarriages, the likelihood of having a fourth miscarriage has been estimated around 34%. So essentially, we're looking at similar odds, similar statistics in terms of experiencing yet another miscarriage after the second one or the third one. So if you've already experienced 2 miscarriages, the chances of experiencing yet another one would be 1 in 3, or 30%. And if you've experienced 3, then the chances are around the same, 34%, that you'll experience yet another one. So why go through something traumatic as that, as opposed to starting your investigation? So that's something that we keep in mind when we're offering our consultations, when we're talking to our patients, because this is a very traumatic process. This is something, especially if you go through 2, 3, or 4 miscarriages, this has devastating effects. And there are numerous studies. There are several studies that have been conducted about this, not about the miscarriages themselves, but the psychological toll they take on people, because it's not something that you can get over very easily. And especially if you go through 1, 2, 3, and then you're pregnant again, you're scared because, again, you could face another miscarriage. And up until it happens, or even if it doesn't happen and you do actually deliver a healthy child, all throughout that pregnancy is very stressful, because you don't know if it's going to be a successful pregnancy or not. So the take-home message from all of this, what I'm trying to say, is essentially, after 2 consecutive miscarriages, we would like to start our investigations, because there is no reason why you should go through a third one and then lose time and go through a psychological trauma. So in most cases, our definition would include 2 consecutive miscarriages. And in most cases, if someone goes through a single miscarriage, we usually don't see any reason why we should be investigating, because most women will, in fact, experience a single miscarriage. And the likelihood of having a second miscarriage, having 2 consecutive miscarriages after the first one, are so small, less than 5%, I would say, that we don't really see the need to investigate into a single pregnancy loss, because the chances are most women, more than 90% of the women, will go on to have a problem-free pregnancy after a first miscarriage. So the first miscarriage doesn't necessarily warrant a further investigation, but after you have 2 consecutive miscarriages, then that's when we start thinking maybe there's something wrong here and we should be investigating a little further. But sadly, we do have patients coming in from all over the world, and sometimes they tell us, "Oh, I've had 5 miscarriages, I've had 6 miscarriages," and there are no investigations that have been performed for 5 or 6 miscarriages. And these people aren't coming from the third world or less developed parts of the world. They're coming from the UK, the US, and sometimes these things can be ignored. And even though they shouldn't be, we do see this, unfortunately. And what we highly recommend is, after a second miscarriage, after a second consecutive miscarriage, definitely look into things, because if there is a reason why you're having consecutive miscarriages, there is probably a reason there. There is probably something that needs to be addressed so that you don't experience it again. And when we're investigating into pregnancy losses, one thing that we need to analyze is when these pregnancy losses are being experienced. Is it earlier on during the pregnancy, or is it later on during the pregnancy? Are we looking at the first trimester, looking at the second trimester? Are we looking at very, very early within the first month of the pregnancy, or are we looking at something that suggests maybe something more structural and not developmental? So these are the things that we do keep in mind. And also another very important factor to keep in mind is the age of the mother, of the biological mother. The reason why I'm emphasizing, and it's in italics here as well, or the reason why I'm emphasizing biological mother is because not not all the pregnancies are with your biological children, and you could have IVF treatment with donor X, and that means you're not pregnant with your biological child yourself. So you could be 50 years old, 55 years old, and having a pregnancy without much of a risk of a miscarriage because you're using donor X. So that's why I make that distinction here, even though it's not relevant to this topic, but it is good to make a distinction. So if you're carrying your own biological child and you're over the age of 40 years, then yes, there's a very high chance that you might experience a miscarriage. And this has been estimated to be around 50% for women over 40 years of age. So it's quite a high percentage when we're talking about pregnancy after 40 years of age. Okay, so we do have a nice diagram here, which shows us the percentage allocation of the causes of repeated miscarriages. So this is not just for one miscarriage, because one miscarriage may not necessarily have a reason behind it. But if you are experiencing two or more miscarriages that are consecutive, then these are the possible causes. And if you look at it, there is a high percentage with the green section that says unknown. So there are still things that we don't know. There are still things that we cannot identify. So these are the category that we just say, oh, it's unknown. But the rest of them we are able to identify, and we can categorize them, and we can test most of them, and hopefully be able to give you a chance of having a pregnancy with a much, much lower chance of having a miscarriage. So if you look at the previous diagram, genetic causes are around 2 to 5% of all the miscarriages. And then you have the anatomical problems, anatomical and structural problems. And then we have autoimmune problems, infections, and hormonal problems. So these are the types of problems that you could be facing when you do have consecutive miscarriages. And I would like to begin with the genetic disorders. Even though it is a smaller percentage of the miscarriages, even though we just said that it's 2 to 5% of the cause of the repeated miscarriages, it is one of the relatively less invasive and easily identifiable causes of miscarriages, because you could have a blood test and you could check your chromosomes, you could have a karyotype analysis, and easy as that, you could actually have some answers for you. Karyotype analysis nowadays is very reasonably priced. It's not invasive. It's just a simple blood test. Of course, if you're afraid of blood tests, it is a little invasive in that respect, but otherwise it is as simple as a blood test and relatively cheap nowadays that we have all this technology, and it could give you some answers. So even though it doesn't make up a large percentage of the causes of recurrent miscarriages, it is an easy test to do, and it is relatively straightforward. So we would usually begin with something like this if we do have a couple going through recurrent miscarriages, going through recurrent pregnancy losses. This is usually where we would start, and then move along into perhaps more invasive or more expensive tests. So in terms of genetic disorders, we could be looking at two different types of chromosomal abnormalities. These are numerical or structural. And in terms of numerical abnormalities, we're looking at chromosomes numbers that are less or more than they're supposed to be. And structural problems have to do with the structure of the chromosomes, such as deletions, insertions, or translocations. We're going to talk about these in a little bit. And you could have the problem with the parents, or you could have the problem with the embryo. So you could have the parents having chromosomal abnormalities that they may not be aware of, or you could have normal karyotype with the parents, but the offspring, the fetus, the embryo could still have chromosomal abnormalities. So there are two different types of chromosomal or genetic disorders that we're talking about here, essentially. If the parents have the problem, or if the offspring actually has the problem, even though the parents are chromosomally euploid or normal. And even though it's easier to identify problems with the parents because you can check their chromosomes, you can offer testing and screening, but with the fetus, it's not so straightforward because you don't necessarily know where the chromosomal abnormalities are coming from. You could try to screen the embryos, but that's, of course, one step beyond, and it would require IVF treatment. But where we are right now, we're talking about chromosomal abnormalities with the parents and how we can prevent that from happening. So as I've mentioned, there are numerical or structural abnormalities. And when it comes to numerical abnormalities, we're looking at chromosomes numbers that are less than or more than what a normal human being is supposed to have. And this could happen. Some people could have additional chromosomes or less chromosomes than they should be having. But these syndromes are usually very evident. So you would know that you would have this syndrome earlier on in your life. So it wouldn't usually go unnoticed, even though sometimes it may be. But structural chromosomal abnormalities can go unnoticed because they essentially sometimes they do not present with any clinical presentations, any clinical features in the person carrying them, especially when we're talking about the common ones such as translocations. We could have reciprocal translocations, or we could have Robertsonian translocations. And even though these are very technical terms, and I will try to keep this conversation very simple, I don't want to go into the whole jargon of genetics and bore you to death here at this hour. But these are very common, and they do happen, and we do see patients carrying these translocations. And even though it doesn't affect them, it could affect their offspring. And essentially, with reciprocal translocations, we're talking about fragments of two different chromosomes that are essentially switched. So you're looking at exchange of parts between two separate chromosomes. So one little part, one little fragment of one chromosome is essentially ripped apart from where it's supposed to be, and then another fragment of another chromosome is separated from its own chromosome, and these two are in a way switched, and they kind of replace each other. And these do happen quite frequently. And even though the carrier, the person who does have this translocation, isn't aware because it's a balanced translocation. So one part of the chromosome is replaced with another part of another chromosome. So both chromosomes, in a way, are complete with the fragments that don't belong to them per se, but they're still complete. They're not missing anything. So it doesn't really affect, it's not as big of a switch that would affect the function of the chromosome or the genes on the chromosome. So these reciprocal translocations, they do not show any clinical signs on the carrier. And then we have the Robertsonian translocations, and these are more of a fusion between chromosomes. So it would end up reducing the number of chromosomes from 46 to 45. So these would be more evident and, in fact, change the function of the chromosomes or the genes. But more often than the others, we do see reciprocal or balanced translocations. Patients have no idea that they have it because it does not affect them in any way. But they go through these number of consecutive miscarriages, and we do a karyotype analysis, and we see a translocation between two chromosomes. It's balanced. The patient doesn't feel anything, doesn't feel differently, but it's there. And when it comes to creating their offspring, this balanced translocation may not be so balanced anymore, and it could actually create an offspring with an unbalanced translocation, which could change the function of the chromosome and the genes on that chromosome. So we're looking at a genetic abnormality with the child, with the offspring, and then we're looking at a miscarriage. So what we do in that case is the first thing when couples come in for a consultation, what we do is we ask for a karyotype analysis. And once we see the karyotype analysis, if there is anything like a translocation, then that is something that we could prevent with pre-implantation genetic screening on the embryos. So yes, most likely people would probably need to undergo IVF treatment. And as part of this IVF treatment, we would offer them pre-implantation genetic screening on their embryos. So we would screen the embryos for their chromosomal content, and we would pick the embryos that do not have the unbalanced translocation or the genetic chromosomal abnormalities, and we would pick the chromosomally normal embryos for transfer, and we would reduce the chances of having another miscarriage. So that's one thing that could be done if we're looking at a problem that is caused by a translocation. And then secondly, we do have anatomical and structural abnormalities, and these are the abnormalities that have to do with the reproductive tract. This could be the cervix or it could be the uterus. So if you're looking at the uterine problems, if you're looking at the problems with the uterus, these are most likely to be congenital problems. And if you're looking at structural problems, then we're essentially looking at cervical incompetence, cervical insufficiency that could be causing the miscarriages. And one of the things that we mentioned at the beginning of this talk is when you're investigating into miscarriages, it's very, very, very important to identify when the pregnancies are being lost. If it's earlier on, then we're probably looking at embryonic problems, genetic problems, or other immunological, hormonal aspects of the pregnancy. If we're looking at later stage miscarriages, later stage pregnancy losses, then we might be looking at problems with the cervix and cervical incompetence, and the cervix may not be competent enough to carry the pregnancy, and then it would open up, and normally it should stay closed throughout the pregnancy, but it may open if it's incompetent. And the reasons why there might be that issue to begin with, the reason why you might have an incompetent cervix might be because of a previous trauma into the region, could be because of a previous surgery, could be because of a previous DNC, could be because of a previous very difficult labor that caused damage to the cervix. So there could be a number of reasons that could cause structural problems with the cervix and the cervix being incompetent. In that case, then yes, this is relatively easier to identify, obviously, during ultrasound scans. So you would need extra monitoring during the pregnancy, and stitching or other alternative options are there to support the pregnancy so that it can actually go into a full term. And as I've mentioned, this is usually something that we would see in the after 12 in the second trimester. And in terms of anatomical abnormalities, we're looking at things that usually happen during the before you're even born, during the embryological development. The reproductive tract is formed, and the ovaries are formed, your eggs are in there, so you don't produce eggs after you're born. You're born with all the eggs that you're going to need throughout your lifetime. And same goes for the reproductive tract. So the entire reproductive tract, including your eggs, they all form during embryogenesis, during the embryological development. And if there is any error during the fusion of ducts, then you're looking at congenital abnormalities of the uterus or the reproductive tract in general. And these can lead to problems such as not having enough blood supply or disrupted development of the reproductive tract in general. So you're looking at problems that you're born with that could prevent you from having a child because the uterus is not developed enough. It does not have the vasculature to support the development of a child. And you may not necessarily know all this until you're experiencing problems, until you're experiencing a miscarriages later on, and then you could find out that there might be a anatomical abnormality with the uterus. And another congenital problem with the uterus would be a septate uterus. So there would be a septum in between, and it could negatively affect progression of the pregnancy. Okay, and then we do have immunological disorders. These are also very common, and probably as we go along, as we discover more things in terms of the human body, in terms of the immunological processes, we will probably discover that more of the miscarriages, more of the problems that we're having might have to do with immunology. And even though our bodies are designed perfectly in a way to fight with foreign invaders, to fight with foreign threats, there could be issues with our immune systems as well. And if your immune system is overactive or underactive, you could still have problems. So it's not one way or the other. It's not because you have an overactive immune system that's trying to fight with the embryo. It could be an underactive immune system as well that's creating problems. So either way, with immune system related issues, you might be having fertility issues or miscarriages. When I say fertility issues, I mean not being able to achieve pregnancy at all. And normally in a natural pregnancy, because as you know, half of the genetic material comes from the father, half of the genetic material comes from the mother. So essentially, you're looking at a embryo that possesses 50% of the genetic material from the father. So for the mother's immune system, for the mother's body, 50% of this embryo is actually foreign. So it should, in a way, recognize it as a threat and try to kill it off. But there are a lot of pathways, there are a lot of mechanisms that prevent this from happening. And actually, there are several theories, 10 different mechanisms that are believed to prevent that are believed to prevent this from happening, to prevent the mother's immune system from being too active against the embryo. And in terms of how your immune system might be causing miscarriages, we do have two different categories. We have the autoimmune problems and we have the cell-mediated problems. And with the autoimmune problems, I'm sure you have heard of this before. I'm sure you have heard of this autoimmune problems, such as systemic lupus, such as arthritis, such as antiphospholipid syndrome, and several autoimmune problems that are causing problems, but they're also causing miscarriages as well. So thyroid, anti-thyroid antibodies, so autoimmune thyroiditis, uh, again, antiphospholipid syndrome, lupus. These are all autoimmune conditions that could interfere with a successful pregnancy because you have an overactive immune system, because you have antibodies in your body that are, in a way, fighting with your own cells. And that becomes problematic during during the pregnancy as well. So even though I've listed some technical terms here, some jargon, essentially what we're talking about here are antibodies that your body is producing, and these are essentially your body's response to foreign invaders. So even though there is no foreign invader in your body, sometimes your overactive immune system is trying to fight off something that it believes it's foreign. So in a way, it's attacking the body's own cells, believing that these are foreign cells. And what I've listed here as antiphospholipid, anticardiolipin, anti-nuclear, lupus anticoagulant, anti-single-stranded DNA, anti-double-stranded DNA, and anti-histone antibodies. These are the types of antibodies that we see in certain autoimmune conditions. So, such as SLE, such as antiphospholipid syndrome, such as autoimmune thyroiditis. So these are some of the syndromes, some of the conditions that come with these antibodies that might be affecting your pregnancy. And even though, for example, you may have the anti-double-stranded DNA, you may have the anti-nuclear antibody in your system, but you may not necessarily show clinical signs of SLE. You may not show a clinical picture of lupus. You may not have the typical butterfly rash. You may not have the arthritis. You may not have the muscle pain. You may not have the fever. You may not have the nephritis. You may not have the lung involvement. So you may not show any clinical signs of SLE, but you may still have the antibodies in your system, which puts you at an elevated risk of developing SLE somewhere down the road. You may never develop it, but if you do have the antibodies in your system, then this might actually have something to do with the miscarriages that you're experiencing. So even though you don't show signs of autoimmune disorders, that doesn't mean that you don't have the antibodies for them. So it does make sense to test for these antibodies as well, to know. And autoimmune is one aspect of immunological disorders. And then we have the cell-mediated immune responses that are more, could be local or systemic as well. But it has to do with the cellular activity of certain cells. According to research on this, and there have been substantial amount of research to identify miscarriages because it is a worldwide problem. So there is ongoing research, and recent research does show that in pregnancies that do end up with miscarriages, there is lower level of CD3 positive T cells. So women who do experience miscarriages, they do exhibit much lower levels of CD3 positive T cells in the first trimester. And the CD3 antigen is much lower, which essentially the theory is this: the fact that the population of CD3 positive antigen is lower is possibly because the more dangerous CD19 positive antigen, which is the antigen that's exhibited by the natural killer cells, is elevated. So essentially, you're looking at a lower level of the CD3 positive T cells, and you're looking at a much higher level of natural killer cells during the first trimester. And this is, in fact, causing problems with the pregnancy. So that is something that could be addressed as well. So immunological disorders are a really a large part of miscarriages, and even more so as we discover more about the immune system, as we discover more about cellular responses, autoimmune problems, and as more tests do become available, we do see that more and more miscarriages are in fact attributed to cellular level problems or autoimmune diseases. And then we have the thrombophilia disorders as well. These are still and they do constitute a large portion of the miscarriages. And they are relatively easier to test, relatively they're not costly as they become more widely available. The cost has gone down. It used to be significantly costly at one point, 10, 15 years ago. These tests would probably run about £2,000-3,000, but nowadays they're much, much cheaper because they are more widely available. They are being offered to a greater number of people. So as they are more and more readily available, the cost of administering them does go down as well. So they are less costly, and they are also performed using venous blood. So peripheral blood sample, just like taking blood from your arm. It is 2 minutes. It's not costly. It's something that could be tested relatively easily, and within a few days you would get the results. So this is something after the karyotype analysis. If the karyotype of the patients are normal, if there are no karyotype problems, this would be the second test that we would offer the patients probably, because it's cost effective, it's easy to administer, it's not invasive, and it just takes a few days to get the results. So this is something that we would do next. And it is relatively common, and it is a condition that could possibly cause blood clotting. So thrombophilia is known as a blood clotting disorder. So your blood clots more easily than others. And a blood clot causes a thrombosis. So this is not just important for miscarriages. People who do have a thrombophilic disorder, people who do have blood clotting disorders, they do actually have a higher risk of cardiovascular events as well, because blood clot is never a good thing to have in the body. So this is something that needs to be monitored. If you do have a blood clotting disorder, if you do have a thrombophilia disorder, this is not only important for having a child, this is also important for your overall health. So this is something that you would need to discuss with your internist, with your GP, or with your cardiologist to have regular checks so that you're not at an elevated risk of cardiovascular events either. But in terms of course, we're not talking about cardiovascular events right now. We're talking about miscarriages. We're talking about recurrent pregnancy losses. So from that perspective, if you do have a problem with blood clotting, you're looking at essentially a blood clot could happen anywhere. So it could be happening at the site of embryo implantation. So it could be in the endometrium. And if there is a blood clot in the endometrium, the baby, the fetus, the embryo will not be able to implant. So a blood clot at the site of embryo implantation could cause a failed pregnancy. So the pregnancy does not form to begin with because there is a clotting disorder at a site where embryo is supposed to be implanting, and it is supposed to have access to this vascular bed where it receives its nourishment, it receives its nutrients. But if there's a clotting disorder, then that may not be possible there. At the same time, even though there is no blood clotting problem at the embryo implantation site, you could be looking at a problem further down the road where you're actually pregnant and the placenta has formed, but through this placental circulation from your blood supply, a blood clot could actually pass down to your fetus, and through the placental circulation, it could possibly stop the heart of your baby, of your fetus. And then that's why you might actually have a missed miscarriage, a missed abortion, everything going normally, and then you see the heartbeat, you can hear the heartbeat on the monitor, and the pregnancy is developing at 12 weeks, and then after 12 weeks you go and you see that the fetus, there's no heartbeat, the heartbeat has stopped, and then the pregnancy has stopped. And this is a possible explanation. It could be a blood clotting disorder. There could be a blood clot going into the baby, and this could be why you might be having miscarriages. And again, it is relatively simpler to test, and it is one thing that we do usually as during the first consultation. This is one of the things that we suggest doing because it's relatively easy. And why do we have thrombophilia defects? Why do we have blood clotting problems? They're essentially mostly caused by mutations in genes or gene products, or deficiency of certain genes or gene products, such as the deficiency of protein C, protein S, antithrombin 3, and these are known as the anticoagulants in our body. So these are what keeps the blood flowing problem-free, that are preventing clots from developing. And certain gene defects, such as the genes of MTHFR, this is on our next slide, the methylene tetrahydrofolate reductase, MTHFR is the abbreviation. It's much easier to pronounce, I guess. Especially MTHFR C677T and MTHFR-A1298C are the two gene mutations that we see in people with thrombophilic defects. Prothrombin, which is also known as factor 2, PI1, and factor 5 Leiden mutations are also the common mutations that we see in thrombophilic disorders. So usually these 5 mutations, the MTHFR-C677T, MTHFR-1298C, factor 2, factor 5, and PI1 are the 5 gene mutations that we test for. And then we also look at the protein S, protein C, and antithrombin 3 activities to see if there's any deficiencies there as well. So as I've mentioned, this is a relatively easier test. It's a blood test. You could have a peripheral blood drawn from your arm, and then you could have the test results within the next few days. And we do have infectious diseases as well as a potential cause of miscarriages. But I need to mention this, that in the past, we believed that torch infections, the infections such as Toxoplasma, Rubella, CMV, HSV, were causes of recurrent miscarriages. But nowadays, we don't believe that anymore. Even though such infections, toxoplasmosis, rubella, CMV, HSV, could be causing a pregnancy loss in the active state of the infection, they're not likely to be causing recurrent miscarriages, because these infections, when they're active, yes, they do have the potential of interfering with the pregnancy. They do have the potential of causing a miscarriage. But once your body develops a defense mechanism against them, then they're less active, and they're not active anymore, actually. And they don't have the potential of harming your baby. They don't have the potential of causing a miscarriage. So if you have had one miscarriage and you're looking into the reasons, you're investigating into the reasons of why this might be, then the torch investigation, the torch infection investigation, yes, would be a good idea. So you can see if you have toxoplasmosis, rubella, CMV, or HSV. But if you've undergone 2 consecutive miscarriages, it is less likely, much less likely, that these 2 miscarriages are actually caused by the same reason, which is an infection. This is less likely because the infection would not be active by that time to be lasting for 2 consecutive pregnancies and miscarriages. And at this point, of course, we can distinguish between the IgG and IgM antibodies, and these are our immune responses, obviously, for um, for the infection. So when there's an infection in our body, there is an active phase antibody, which is the IgM. So the IgM antibodies are produced right after the infection, right after we're exposed to the infection. We do produce IgM antibodies, and they're there for a couple of months, which suggests that the infection is active. So we actively have the infection for a couple of months, and that is when the IgM antibodies are elevated. But after a couple of months, the IgM starts to decline because the infection is no longer active. And we do have the long-term response to the infection, which is the IgG, and that starts to increase after a couple of months, and it becomes elevated later on as well. So after you've been exposed to an infection such as toxoplasmosis or CMV, they will remain there. Your IgG will remain there because these antibodies are produced, and they suggest that you're immune to this problem now. You've had the exposure, you've had the infection, but now you're immune, so it cannot affect the pregnancy any longer. But if you're IgM positive, then yes, you do have the active infection or recent infection, and it does have the potential of affecting the pregnancy. And then finally, I know it's been about 50 minutes since we've started, so I'm just going to try to cut it a little short. We do have a couple of slides left anyway, so we're almost there. Bear with me. We just have a few more slides, and then we'll move into the Q&A. And in terms of hormonal problems, in terms of hormones, our bodies are endowed with several hormones, would have several metabolic processes, would have several functions, and these hormones, they all have very specific jobs, very specific signaling mechanisms, and if something goes wrong, and then that mechanism, that pathway might not work anymore. And they do they do have a lot of interconnected communication between the hormones as well. So if you do have a hormonal problem with a specific hormone, it could actually affect something downstream from there, and you would actually have something totally unrelated to that specific hormone, but actually because of its communication with the other hormones, then you might be looking at something unexpected. So for example, I've listed a number of things here, such as thyroid problems, adrenal gland problems, and diabetes. These are all known risk factors for miscarriages because they do have such an impact on the hormones. Take the thyroid problem, for example, hypothyroidism. We know that hypothyroidism reduces the amount of sex hormone binding globulin. And the sex hormone binding globulin, a reduced level of sex hormone binding globulin, does have an effect on prolactin. It does elevate the amount of prolactin. And prolactin, we know, interferes with progesterone. So it is not the hypothyroidism per se, but it's how it affects everything else downstream. It reduces the available sex hormone binding globulin, which in turn increases the amount of prolactin. And prolactin interferes with progesterone, and it reduces the amount of progesterone available. And we all know that we need progesterone. If you've gone through IVF, or if you know about reproductive physiology, you know that after the luteal phase, after the first 14 days of your menstrual cycle, you do start to produce more and more progesterone, because what progesterone does is after estrogen helps build up the endometrium, gets it thicker, progesterone helps to keep it thick for the embryo to implant and start receiving nutrients from it. So without progesterone, you wouldn't be able to maintain a thick enough endometrium for the pregnancy. So you see that because of the hypothyroidism problem, you could in fact end up with a problem with the amount of progesterone that you have, and that could be the reason why you're having a miscarriage. So in terms of hormonal issues, everything is very interconnected, and everything that you may not even think could be related to a miscarriage could in fact be related to a miscarriage. And that is why we need to investigate into things after your second miscarriage. And glucose, it's dangerous to us. It's dangerous to the baby because it's teratogenic. Too much glucose in the mother's circulation, transferring down to the offspring, they do cause embryonic malformations during the development of the embryo of the child. So we're looking at severe developmental problems, miscarriages, or even if you don't have a miscarriage, then you could be looking at a severely malformed child going to full term. So all of this jargon, all of these technical terms, all of these problems that you could be facing, I know it's more scary. It looks more scary than it actually is because thank God we do have a few tools at our disposal. We do have a few tests that we could run, and depending on the test results, we do have a few tools that we're equipped with so that we can actually help reduce the likelihood of this problem. And as I've mentioned at the beginning of this talk, one miscarriage, one pregnancy loss does not usually call for further investigation because these investigations, even though, yes, some of them are relatively less expensive, some of them are relatively non-invasive. After one miscarriage, we don't necessarily believe there is a reason behind the miscarriage because most of the time, more than 90% of the women who have one miscarriage will go on to have a healthy pregnancy the second time around. And it's only after the second consecutive miscarriage that we start thinking there might be a problem because I see some of the questions saying that I've had two consecutive miscarriages, but on the third one, I did actually have a healthy pregnancy. Of course, that's perfectly normal, and it is actually it is a bigger chance of having a normal pregnancy after two consecutive pregnancy loss than having another pregnancy loss. Because at the beginning of the talk, we talked about the statistics a little bit, and we said, if you've had two consecutive miscarriages, the chances are there's a 30% chance that we'll actually go on to have the third one. So there's a 30% chance that you'll have the third consecutive miscarriage, but there's a 70% chance that you won't have the miscarriage. So that's something, that the odds are in favor of you not having a miscarriage, but 30% is not something that's too small. That's not something that we would like to risk. So yes, there are many women, more women would go on to have a natural pregnancy and a successful pregnancy compared to the women going on to having third or fourth miscarriages. But at the end of the day, if you've gone through two miscarriages, two traumatic experiences, two things that have caused you depression, that have caused you great psychological distress, then we don't believe there is reason why you should go through another one, even though it's a 30% chance of having it, and there's a greater chance of you not having it. But still, it makes sense to start looking into things, maybe start with the basic things, start with the basic blood testing, and the cheaper investigations and less invasive investigations, and then work our way into more comprehensive ones. So depending on your unit, of course, it's not step-by-step procedure, which is the same for everybody who experiences a miscarriage. Depending on when you experienced a miscarriage, depending on your family history, depending on your own history. For example, if you've just had one miscarriage and if you do have cats in the house, we might think, okay, maybe a toxoplasmosis infection that could be causing the single miscarriage. So that's something that we could, test right away without testing anything else. If you do have a positive family history of females having miscarriages in the family, then we might be looking into other problems that might be autoimmune with a genetic aspect. If you have nothing problematic and everything seems to be fine, maybe maybe the chromosomal testing, the karyotype analysis will show that there is in fact a translocation. So there are things that we can do, and there are things, different aspects, different approaches, more correctly, different approaches that we can employ for different people depending on their own medical history, depending on their own reproductive history. So as I've mentioned, these have been mentioned throughout our talk, but to sum up, the further investigation that we would do normally with what we know currently is a karyotype testing to test the chromosomal aneuploidies, the possible chromosomal aneuploidies, a thrombophilia testing, which is testing for blood clotting problems. Uterine assessment essentially would be looking into the uterus to see if there are any congenital malformations and any problems that might be there because of the anatomical problems. Autoimmune testing, especially the antiphospholipid syndrome, is one that is highly related to miscarriages. So this would show usually with a family history as well, a family history of females having miscarriages and possibly previous blood clotting problems, previous deep vein thrombosis. This could possibly show. And the hormone testing as well, if everything else comes back normal, or since the hormone testing is still relatively inexpensive, it's relatively less invasive, that could be one of the first tests that you could do. You could check for certain hormones and see if that's where the problem is stemming from. So these are some of the references that I've used for the numbers that I've provided for certain things. These are here. So when you watch the video again, if you want to revisit this video, you could use these references to further look into some of the statistics that I've provided. And this concludes my presentation. I know it's been an hour, and normally we're supposed to keep them, I guess, a little less than an hour, but hopefully you bared with me and you haven't fallen asleep. And thank you for being there and listening.
Thank you so much, Dr. Ahmed, for this fantastic presentation, for all the information. Yes, that was a little bit longer, but we definitely do not mind. So I believe we do have many questions already. So let's move on and let's start with the first one. Should you take aspirin to reduce the risk? And I will show you the next one as it is very, very similar to this one. I am at 11 weeks. Does my chance of miscarriage reduce at 12 weeks? What is the most common reason for miscarriage after 12 weeks?
Okay. So in terms of well, let's do the first question first, if you will. Aspirin, does it reduce the risk? It depends. It depends on what the problem is. If your problem has nothing to do with a clotting problem, if your problem is not something that could be fixed with aspirin, then obviously aspirin is not going to do anything. If you don't have a problem that the aspirin is there to fix, then it will not help. Usually, yes, during a lot of pregnancies, aspirin could be used. Most of the cases, it's not detrimental. So, especially women who've experienced a number of miscarriages, they do take aspirin. It's the jury is still out on that. Sometimes we do like to use aspirin as well, because it just gives us a peace of mind that we're actually doing something different as well. But in our experience, aspirin, unless there is a reason why we should be giving aspirin, I don't think that aspirin will fix the problem, because it just depends on whatever your problem is. And taking aspirin without knowing where the problem comes from, it's not very likely to fix the problem. But it is a precautionary measure that could be taken. But if you're looking at, for example, an MTHFR mutation, if you're looking at a PAI1 mutation, if you're looking at one of the thrombophilia problems, one of the mutations in the genes that we've mentioned, MTHFR-C677T, A1298C, PI1, prothrombin, factor 2. So if you're looking at mutations in these genes, or if you're looking at reduced activity of proteins C and S, then you're looking at a blood clotting problem that's not going to go away with aspirin. You're looking at something that requires low molecular weight heparin injections, so that you can actually take care of the blood clotting problems. And you would probably need to use that all throughout the pregnancy if you do have a thrombophilia defect, if you do have a reason why you should be using anticoagulants. So that's my answer to the first one.
Okay, perfect. Thank you for the question as well as the answer. And sorry, there was another one that was similar. However, I just put the wrong one by accident. Sorry about that.
Because I was thinking it's not very similar.
But yes, the one. Sorry about that. So I'm over 40 and I have had 2 miscarriages and 1 healthy baby. Should I take aspirin? Anything else I can do to prevent a future miscarriage?
Okay, so over 40 years old and to have 2 miscarriages and 1 healthy baby. So I'm assuming that the 2 miscarriages happened before the age of 40, and then there's a healthy baby, and now the patient is over 40 years old. And anything to prevent a future miscarriage, unfortunately, age is a very important factor. And one of the things that comes with age is chromosomal problems, and not with the patient themselves, but with the baby. So the higher the age of the mother, of the biological mother, the more chromosomal problems we see with the offsprings. So even though everything might be perfect, even though the patient may not have any of the problems that we've talked about, just being over the age of 40 does put her at an elevated risk of chromosomal problems with the baby. And it is those chromosomal problems that are likely to cause the miscarriage rather than anything that the patient might be doing. So for Claire, I would say taking aspirin during the pregnancy, yes, it is something that could be done. It is a precautionary measure, but taking aspirin is not going to eliminate the risk of the chromosomal problems with the child that comes with the age. And that is something, Down syndrome is something that we see more often. Other chromosomal aneuploidies that are not compatible with life is something that we observe more often. That is why most of the time when you see someone over the age of 40, you do see more miscarriages with them. For example, if you hear something having a miscarriage, they're more likely to be a little older than 40 years old. Of course, younger people do have miscarriages as well. That doesn't mean that young people don't have miscarriages. Of course, they do, but there is usually a reason why they do, such as the ones that we've talked during this webinar. But over 40, we're mostly looking at chromosomal aneuploidies with the child, chromosomal problems with the child that comes with oocyte aging, that comes with the aging of the eggs. So when the eggs age, because as I've mentioned at one point briefly during this conversation, during this webinar, every woman is born with a finite set of eggs, and these eggs do not replenish, they do not reproduce during the lifetime. So you're born with the eggs that you're going to be using for the rest of your life. So you are born with these eggs, and as you age, so do they. So your eggs right now are over 40 years old as well. And with the aging of the eggs, they do start having more and more genetic problems. And the more genetic problems they have, the more chromosomal aneuploidies we see with the offsprings that are produced with these aging eggs. So over the 40 years of age, not much you can do in terms of the genetic aspect. Yes, you could take aspirin to reduce further risks of other problems, but otherwise, over 40 years of age, you're always looking at an elevated risk of a miscarriage because of chromosomal issues.
All right. Thank you so much for this explanation as well. And let's go back to the previous question, of course. Here it
Okay.
is. I am at 11 weeks. Does my chance of miscarriage reduce at 12 weeks? What is the most common reason for miscarriage after 12 weeks?
Okay. So anything that we've discussed could actually happen before 12 weeks or after 12 weeks, except for the cervical incompetence. Cervical incompetence usually happens after 12 weeks because the baby starts to grow a little bit bigger, and then the cervix, being incompetent, is not able to carry it anymore. So it just opens up, and then the baby is lost. So apart from that, which requires a certain height and certain weight of the baby. Otherwise, the rest of the things that we've discussed could happen either before 12 weeks or after 12 weeks. But most of the time, if we're talking about autoimmune, if we're talking about immunological problems, if we're talking about genetic problems, they most likely happen before 12 weeks. So most of the time, that's our timeline as well. When, like we always say the same thing to our patients as well. 12 weeks is a milestone in a pregnancy. So once you go beyond the 12-week period, once you go beyond the first trimester, then we take a breather. We're more relieved that you've gone past the 12-week period, because after 12 weeks, yes, the chance of pregnancy losses will go much lower. But with thrombophilia defects, they could happen at the time of implantation in terms of blood clots. So they could actually prevent implantation and prevent a pregnancy. So you may never have a pregnancy because of thrombophilia defects. Or after pregnancy, you would be looking at a thrombus going into the baby's circulation. And these are more likely to happen after 12 weeks, because your placenta needs to form, and then the placental circulation needs to be sufficient so that this blood clot can actually travel into the baby's heart. So you're probably looking at you're still looking at a risk of a thrombophilia problem causing the miscarriage after 12 weeks as well, cervical incompetence as well. So going past the 12 weeks does not guarantee that you're going to have a problem-free pregnancy, but it does eliminate the risks to a great extent. So after 12 weeks, yes, we do have a sigh of relief, but at the same time, it needs to the pregnancy still needs to be monitored.
And thank you for that, of course, as well. Let me have a look at the next question for you here. Do you recommend uterine or peripheral blood to test immunes?
Okay, so this is a very, very good question. And this, I think, Zoe is referring to natural killer cells, because there are two alternative ways of testing for natural killer activity. One is in the peripheral blood, and one is in the uterus. So you could test, you could biopsy a small part from the endometrium, or you could test the natural killer activity in the peripheral blood. And there are several articles on this. There are several studies on this, which show that the peripheral blood natural killer activity does not necessarily correlate to the natural killer cell activity in the uterus, in the endometrium. So you could actually have a higher load of natural killer cell activity in the endometrium that does not necessarily occur at the peripheral blood level. So it's not so much in the circulation per se, but is more localized in the uterus, in the endometrium, where the baby is supposed to implant and the baby is supposed to grow. So um, we usually recommend, if we do suspect natural killer cell activity, if we do have a reason to believe that this might be the case, then and if you are willing to go through the testing, because after the testing, there are certain things that you can do. If you do test positive for natural killer cell activity, then immunoglobulins, IVIG, there are certain things that you could do And these things could be done without going through the invasive endometrial biopsy for natural killer selectivity. And that is something that could be done as well. But if you would have a test for natural killer selectivity, I would definitely recommend the endometrial one, because it is where it might be localized, and in peripheral blood, maybe you don't see much of an activity, but in the endometrium, there might be elevated localized activity of natural killer cells. And with the peripheral blood, you're not going to get the answers that you're looking for.
Perfect. Thank you so much for this, for another question and your answer. We have a longer question here.
Okay.
Hello, Dr. Ahmed. You stated in your presentation that half of the pregnancies will end in this miscarriage when the mothers over 40 years use their own eggs. Can maternal spindle transfer or cytoplasmic transfer help with the issue, as some studies shows that this technique improved pregnancy outcome in older mothers and have resulted in live birth?
Okay, so Claribel has done her research, I can tell. That's an excellent question. That's a very knowledgeable, intellectual question. I love this question. In fact, it could help, but to a certain extent, because cytoplasmic transfer, the idea behind cytoplasmic transfer is the fact that as we age, so do the eggs, right? As the female body ages, so do the eggs that come with it from birth. So with the idea behind cytoplasmic transfer is that you're using the cytoplasm of an egg donor. So you're harvesting eggs from an egg donor, from a young and healthy egg donor, and you're using the cytoplasm from the eggs of the egg donor, and you're injecting them into the eggs of the biological mother, of the intended mother. So you're not doing anything with respect to the genetic material per se, but you're injecting the cytoplasm into the genetic material of the intended mother, so that you can provide it with a better host, a better environment, because we know that cytoplasm contains the mitochondria, and the mitochondria are the powerhouses. The mitochondria are what mitochondria produce the necessary energy for cellular growth. It's in our cells, in every single cell that we have, and eggs are no exception. So if you would take out the cytoplasm from a healthy donor egg and inject it inside the eggs of the intended mother, you're essentially giving the genetic material of the intended mother a better chance of survival, because you're providing that genetic material with a better host, better source of energy, if you will. So yes, it would reduce the amount of miscarriages, because not all the miscarriages have to do with chromosomal problems. So you would definitely eliminate some of it. You would definitely eliminate some of the problem, because you're essentially giving the eggs a better host, a better environment to thrive, to survive, and to fertilize, essentially, and then keep growing. So yes, that is something that would reduce the risk of a miscarriage. But obviously, cytoplasmic transfer does not eliminate the genetic problems, because you're still using your own genetic material, and that genetic material is still aging with the eggs, no matter how much of a better environment you're providing it with.
Fantastic. Thank you so much for yet another question and excellent answer. And let me go to the next one. I have the similar question, I guess. You said that half of the pregnancies will end in miscarriage when the mothers over 40 use their own eggs. How is it possible to prevent that?
Well, there are certain things that could be done. If you're over 40 and you're going for a natural pregnancy, then there maybe certain supplements could help you a little bit to keep, like antioxidants and this and that, of course, like to help keep the body healthier relatively. But they have very limited use. They have very limited impacts and effects. But if we're talking about IVF pregnancies, if we're talking about going through IVF, then there are certain things that could be done with IVF, such as screening the embryos, or recent studies. That is something that we incorporate this into our own clinical practice as well. Use of human growth hormone is something that we administer for patients over the age of 40. For patients who who've gone through IVF before and were not able to get enough eggs, or whose eggs didn't produce any, well, we would harvest the eggs and we would see that the quality of the eggs would be low and they wouldn't fertilize. So when we are faced with problems like that, we do use human growth hormone, and it's been shown not only in research but also in our clinical practice that using human growth hormone is something that does help with the genetic integrity of the eggs, because human growth hormone is a growth hormone, and it supplies with the necessary growth factors, and it comes in handy especially during the meiotic divisions of the eggs. So we would start using them before planning the pregnancy, approximately 6 to 8 weeks at least, up to 10 weeks maybe in some cases, because essentially oogenesis or oocyte development, egg development, is something that takes about 75 days. If we're looking at primordial follicles going into ovulation, we're looking at a timeline of 75 days. So if you have 75 days where an egg would go from an undifferentiated primordial follicle into into ovulation, then you know that for all the meiotic divisions to take place, all the differentiation to take place, it would require 75 days. So if you're going to do anything, you're going to have to do something within these 75 days. So 75 days would be almost 2.5 months, so up to 10 weeks. If the patients have a lot of preantral follicles, then this would be around 40-45 days that we would use the human growth hormone. But if the patients no longer have a lot of preantral follicles and we're looking at more for the primordial ones, then 10 weeks of human growth hormone is what we would recommend. So we do use human growth hormone as a means of offering better meiotic activity, better differentiation, and better genetic integrity for the oocytes, and it does work. It is something that does work. Of course, it does not create miracles, but quite a lot of times I've seen it working where pregnancies failed before. So yes, it is a part of our treatment regimen in patients who are having difficulties conceiving because of oocytes quality concerns.
Fantastic. Thank you so much. And we have another definitely interesting question. Let's have a look. Recent studies suggest that PGD testing does not improve IVF outcome because of a biopsy of the embryo is tested and not the whole, so an abnormal embryo could still produce a normal baby. If this is the case, is this testing still necessary, as it is expensive and does not improve outcome for older mothers, according to the latest study?
Okay, so PGD, or well, I do differentiate between PGS and PGD. Pre-implantation genetic screening, or PGS, is what we use to test the embryos when there is no known cause. PGD is pre-implantation genetic diagnosis. It's used to diagnose a known problem. For example, if the intended parents have the sickle cell trait, or if there is another known genetic problem running in the family that could be passed down to the embryo, that could be passed down to the offspring, then I would call this PGD, pre-implantation genetic diagnosis, because you're doing it for a specific purpose and you're testing a specific gene mutation. But otherwise, if we're talking about PGS, just to screen out all the chromosomes, then abnormal embryo could still produce a normal baby, you're right, uh, especially if there is mosaicism. So there is a whole debate whether when you screen the embryos with PGS and you see that the embryos are mosaic, meaning some of the cells, they have a mutation, but the rest of the cells don't have a mutation. So that's why it's called mosaic, because not all the cells are actually the same. And most of these embryos actually go on to produce normal children without any defects, any problems. But of course, do you transfer something that could potentially create genetic problems, or do you not transfer it? That is something that is highly debated. Some centers are saying that mosaic embryos do go on to produce a normal pregnancy, but sometimes you don't know if it's going to do so. So especially if someone has paid so much money and has suffered so much already, and they're actually wanting to have a healthy embryo transferred, do you really want to transfer the mosaic embryo? That is something that needs to be discussed with the patients, of course. But if there is a mosaic embryo, if there is mosaicism, then I would prefer not to transfer those embryos, because if we do have other healthy embryos, I would never transfer the mosaic ones because I don't know what's going to happen. And as you've said, it's if you've done the biopsy and if you do find that there is mosaicism, it is an abnormality, but it could produce a normal pregnancy, healthy pregnancy, but you're not transferring it, so you're preventing the pregnancy from happening. Yes, in a way, you're right. But in most cases, we're not just looking at one embryo, especially if we're doing PGS, if we're talking about pre-implantation genetic screening, we would want to have more embryos to test so that we can actually have a normal one. And one of the things that we do is, if we believe that there is a limited number of eggs, if we believe that we're going to get a limited number of embryos during the IVF process, what we use what we call embryo banking. So we don't proceed with testing, we don't proceed with an embryo transfer, we just bank the embryos that we've created, and then we offer a second cycle, a second IVF cycle, and we just add more embryos to the batch, so that we have, in the end, we have way more embryos to biopsy and way more embryos to screen for genetic abnormalities. Because if you're just looking at, if you just have two embryos, then once you do the PGS, the chances are you're not going to find anything healthy to transfer. But if you're doing PGS on 4, 5, 6, 7, 8, 10 embryos, then there's a very high chance that you're going to find a healthy embryo to transfer. So what we would recommend usually to patients who have limited ovarian reserves, limited number of eggs, limited number of embryos, we would recommend going through 2 cycles of IVF. Of course, that would not be at a full cost of 2 cycles, because you're not running the PGS, you're not running the biopsy. So it would actually only minimally increase the cost of your treatments, because you're doing 2. But at the same time, it would give you a much higher chance of success, because essentially you're doubling your chances with more embryos. So PGD still works, PGS in a way. PGS still works when you have a good number of embryos to test.
Fantastic. Thank you so much. And here's the next question for you. I came across some article which suggests that PCOS sufferers are at risk of miscarriage. How can this be prevented? I am 43 with PCOS with 2 failed IVF. AMH level is 16. I am currently on metformin 1,500 milligrams daily. I am considering tandem cycle with cytoplasmic transfer. Can this improve my chances of pregnancy and possible live birth? Please, can you suggest what can help my situation and best treatment to follow?
Yes. One of the things is with PCO patients, we know, like, it's still a theory. Insulin resistance, it's still a theory. So we still don't know exactly the mechanism of PCOS. So yes, it could be due to the insulin resistance problem. And this could be involved in other pathways as well. So yes, there is a higher tendency of PCOS to cause miscarriages. So this is something that we already know. But the exact mechanism why this is happening, we may not necessarily know this. And because it's PCO, because we're talking about polycystic ovaries, because we're talking about many follicles, because we're talking about many eggs competing with each other to receive the FSH, to receive the LH hormones, because essentially the gonadotropin releasing hormone released from the pituitary, from the brain, there is a brain ovarian axis. So when the brain releases these hormones are received by the ovaries, and the ovaries respond by developing the oocytes, by developing the eggs. So the GnRH released from the pituitary, and that helps release GnRH releases, signaled by the hypothalamus, releases FSH, LH by the pituitary, and then that's received by the ovaries. So you have FSH and LH hormones helping with the development of the eggs. But if you in a normal ovary, you would have a few eggs, and they would all receive these FSH and LH hormones, and some of them would receive it more than the others, and then you would go into ovulation. With PCOS, you have so many follicles. You have so many follicles in the ovaries. They're all competing with the hormone, and none of them essentially receive a desirable amount of FSH LH to actually reach ovulation. And this may compromise the quality of the eggs. That is one explanation behind it. So we don't necessarily know exactly what the pathway is, what's exactly causing the miscarriages, but that is one explanation. The quality might be, in fact, an issue. And what we usually do with PCOS patients, what we usually recommend PCOS patients is uh, Myo-Inositol supplementation. It comes as different brand names. Inofolic is one of them, and it does help with the quality. And sometimes we do use this with poor responders as well, women with very, very limited ovarian reserves. And we do see that it does help with the quality of the oocytes. So that is something that could be done. But of course, Claribel is 43 years old, and she does have PCOS. So that is something to keep in mind as well, because 43 is a very critical age when it comes to pregnancy with own eggs. So that is something to keep in mind. But PCO, in fact, is something that helps in this case. Because if you're 43 years old without PCO, then we're concerned with not being able to get enough eggs. If you're 43 years old with PCO and IVF, then we would be looking at a larger pool of eggs. And that might actually, if we do this right, if we do use the medication correctly, if you do it in a way to increase the quality of the eggs that we obtain after the IVF protocol, then yes, there is something that could be used to our advantage. And with PCO patients, and as I've suggested, folic supplements are one thing that do help with the quality of the eggs. And depending on the number of eggs, depending on the quality of the eggs that have been observed in the previous IVF cycles that have failed, then alternative options could also be used, such as cytoplasmic transfer, such as a tandem cycle. Tandem cycle is always an option if you're looking at low quality eggs, if you're looking at poor ovarian response, then a tandem cycle is always an option. But before going down that route, there are a few factors, there are a few things that could be tried with your own eggs. There are a few things that we can do to help improve the quality of the eggs, and that's what we would do in the first instance. So, folic supplementation, myo-inositol supplementation would be one thing, and possibly human growth hormone, as I've mentioned before. Human growth hormone could also help if we're looking at oocyte problems.
All right, amazing. Thank you so much. for yet another question and answer, of course. And let me see, we do have a few questions left. Let's go ahead. How do you treat hormonal imbalance that causes miscarriage?
Well, it's important to know which hormonal imbalance we're talking about. If we're talking about high levels of prolactin, then that's something that, like we would need to correct. If there's an elevated level of prolactin, then we would correct the prolactin levels. If there is hypo or hyperthyroidism, we would need to address the thyroid problem. If we're looking at elevated glucose, if we're looking at diabetes, then that's something we would need to address. And if we're looking at progesterone deficiency, if we're looking at low levels of progesterone because of something along the pathway, such as elevated prolactin or reduced levels of globulins, then in that case, we would probably supplement with progesterone, because in IVF pregnancies, we always supplement with progesterone anyways, because when you collect the eggs, in IVF cycles, we do collect the eggs from the ovaries. When you collect the eggs from the ovaries, you collect the follicles with them, because eggs are contained in these little cysts called follicles. And what happens in a in a normal pregnancy is, without IVF, that is, in a natural pregnancy, the egg, after ovulation, it would be released from the follicle, but the follicle would still remain there, and it would turn into something we call corpus luteum. And the corpus luteum would be responsible for secreting estrogen and progesterone. So when you have the corpus luteum, when you have the follicle, the remains of the follicle producing and secreting progesterone, you're keeping the endometrium healthy and thick for the pregnancy. But if you don't have the corpus luteum, meaning if you've undergone IVF treatment and the follicles have been aspirated, the follicles have been harvested and disposed of, because what are you going to do with it? And you collect the eggs, you take out the eggs from the follicles and you use the eggs, but you don't have the leftover follicle, you don't have the corpus luteum. That means you need to provide the patient with progesterone. So that's exactly why we use progesterone in IVF pregnancies, because progesterone simply is not available in the body, because the corpus luteum is no longer there, because you collected it with the egg. But after 12 weeks, the placenta will take over. So the placenta will start producing its progesterone. So you no longer need to supplement the patient with progesterone. So up until 12 weeks, you do supplement it, and then later on, you don't. So depending on which hormone we're talking about, if it's progesterone, yes, you do supplement with progesterone, starting maybe earlier on, so that it does help with the pregnancy itself, origins of the pregnancy, and then later on to support the embryo. If we're looking at diabetes, if we're looking at problems with thyroid, then you need to address those issues. If you're looking at a prolactin problem, you need to address that issue as well, so that you can actually have a healthier pregnancy.
Okay, thank you so much for this one as well. And we have a longer question. Okay, so let's have a look. Hi, I am 39 years old, and over the last 11 years, I have had 4 miscarriages. My most recent miscarriage was 2 days ago. Every pregnancy ends at 7.5 weeks. I have had various tests, and the miscarriage have been diagnosed as unexplained. I also suffer with unexplained subfertility, and after 11 years of trying, have only had 3 natural pregnancies. I have had 2 rounds of IVF, one successful but ended in miscarriage, and one unsuccessful. My embryo development has never achieved top quality embryos. Can you suggest anything that may be causing these issues?
Thank you, Carrie. This is an excellent question, because like she's gone through miscarriages and she's gone through IVF cycles, and everything remains to be unexplained. So we don't know what it is, and the problem is I don't know which tests have been administered. I don't know what has been offered to Carrie. I'm sure they've probably done the thrombophilia testing. I'm assuming they've done the thrombophilia testing. I'm assuming the immunological testing have been administered as well, autoimmune problems, natural killer cells, perhaps. And probably, I'm sure the karyotype testing has been performed as well, because that's one of the things that we do. Hormones, sometimes they may ignore the role of hormones, so they may not administer the hormone testing to the extent that we would like to see. And sometimes, possibly, they may skip the immune problems altogether, and they may not offer that because they don't know where to look and they don't know what to find. So they may simply not offer it. So I don't know exactly which tests have been performed and which ones haven't been performed, but there are certain things that we incorporate into our protocols. This is not going to be a very satisfactory answer to Carrie, because I don't know her history. I don't know her test results. I don't know which tests have been offered. But in our IVF protocols, we use antibiotics for about a week before the embryo transfer, because we believe that if there is an acute or a chronic infection in the reproductive tract, that might affect the implantation of the embryo. So that's something we do as a precautionary measure. We do use corticosteroids, which do reduce the immune activity. It's a mild immunosuppressant. So a few days before the embryo transfer and a few days after the embryo transfer, more like 5-6 days before and 5-6 days after, we try to bring the immune system down a little bit so that it doesn't try to fight with the embryo. So that is also something we use as a precautionary measure when there is something that's unexplained, when there's something that you don't know, and the patient is having miscarriages, the patient is not able to fall pregnant. So you do want to make sure that you're eliminating some of the risk factors, and you're helping them with some additional precautionary measures. So these are some of the things that we do, but at the same time, we would need to know which tests have been performed so far. And miscarriages could also be some of the things that I haven't mentioned in the webinar, because it's not one of the general things. Would be sperm DNA defects, DNA defects with the sperm, fragmentation issues with the sperm. These show themselves later on during the embryo development. So initially, yes, you do achieve fertilization, you do achieve a pregnancy, but later on, sperm-related DNA defects could show up as early term miscarriages. So that is something that we should keep in mind as well. And maybe sperm DNA fragmentation test, if it hasn't been offered already, that is something that could be done. But otherwise, I would like to see the test results, and if possible, you could send them to me. I could take a look at them and let you know which ones haven't been performed, or if they have all been performed, I could possibly suggest some precautionary measures that could be taken, and then hopefully they would help.
Perfect. Thank you so much for this, of course. And we definitely are able to forward any of your questions to the doctor. So feel free to get back to us, and we will be happy to forward it to the doctor, so he would be able to advise you a little bit more on that as well. Okay. We have 2 more questions to go. So let's go to the next one. I have high NK cells, 3 miscarriages back to back through IVF. Is high NK cells a concern and potential cause? I am homozygous of mutation. You can see this right here, which have aspirin and Clexan 4. How would you treat NK cells via IVF?
Okay, so we do have a couple of things that are problematic here: the natural killer cells and the mutation, the thrombophilia defects. A number of mutations with thrombophilia defects and natural killer cell activity. So a number of things that are actually here working against the pregnancy. So first of all, especially homozygous mutations. So heterozygous mutations are relatively milder, but if it's a homozygous mutation, then in that case, yes, Clexane would need to be used for the entire duration of the pregnancy. And I would also check the dosage of Clexane. Is it 0.2, 0.4, 0.6? What strength, what dosage of Clexane is being used? 0.2 is subtherapeutic, and for a homozygous mutation, it would be very weak. So 0.4 is possibly, or even 0.6 possibly, could be used in homozygous mutations. And natural killer cells, yes, they are a concern, and yes, they could possibly interfere with the pregnancy. They could possibly cause a miscarriage. And what we would do usually, what we offer is intralipid infusions, and to reduce the load of the natural killer cells, to reduce the load of the overactive immune activity, if you will. So we do offer intralipid infusions. We do offer prednisolone, which is a corticosteroid to suppress the immune system a little bit. So there are a few possible avenues there. But of course, we would need to see the natural killer cell load, and probably in consultation with an immunologist as well, we would probably need to formulate something, because I'm not an immunologist myself, so it would be wrong to suggest something at this point because I haven't seen test results. But in terms of natural killer cell activity, we do use intralipids and we do use prednisolone. But if there needs to be something additional, if there needs to be something more prolonged in terms of its usage, we would need to involve an immunologist.
All right, thank you so much. Okay, we have one last question. So let's have a look at it. Do you offer maternal spindle transfer in your clinic? And if so, what's the cost, please?
Okay, we do not offer spindle transfers. We do offer cytoplasmic transfers. So which is the opposite of the spindle transfer. So we would essentially use the cytoplasm of the donor and inject it into the oocyte of the intended mother. So spindle transfer, no. Cytoplasmic transfer, yes.
All right. Thank you for that. Okay, that was actually our last question. So thank you all for joining us today, for all of your questions, for of course Dr. Ahmed for joining us today as well, for your time, and definitely an excellent presentation, and of course for answering all those questions. We don't have any more questions. However, I definitely would like you to see that everyone agrees, and as you can see, the presentation was very good, and as you can see, everyone seems to be really satisfied with your presentation and your answers.
I hope that I was able to help. Obviously, like, I know that this is probably not going to cover everything about miscarriages, but I would hope that it would be a good start, so that like, we know where to look and we know how to move forward.
Yes, we are really happy to have you here for sure. I hope that it will, it's just one more time, today, and we will have plenty to come. And I guess that will be it for today. Okay, so also I would like to invite you all to our next webinar that will be on the 5th of December. We will have another webinar, this time with Dr. Diana Obidniak from Ava Peter from a clinic in St. Petersburg. You will be able to register as well. And of course, I hope to see you there. Once again, thank you so much for joining us, and have a good night. Thank you. Bye.
Good night.
Good night.